docuseries called Modern Medical Mafia.
Never even heard the 3 letters, the term, the nothing.
Mafia is small ball compared to what PBMs do. They are steering America's sickest patients into their pharmacy channels. And not only are they steering these patients into their pharmacy channels, but they're massively marking up the price of those drugs.
Patients are getting screwed, and you guys are getting rich off of it. I mean, absolutely filthy rich. $7.3 billion in profits.
There are people literally dying because they can't afford their medicines. They're going bankrupt because they can't afford their medicines. This isn't about luxury. This is about potentially life and death.
Our son Cole was 22. We knew he would have asthma.
When Cole did arrive at the emergency room, he was lifeless.
On Sunday, January 21st, he passed at 10:06 p.m.
Shipping them through the mail could be very hazardous.
They shipped his medication on a 102-degree day. Probably about a week later, we need you up here. He's in rejection.
It can become harmful to a patient and could have resulted in death.
No one's truly ensuring that it's safe. So I had to know, how much are they profiting? This has a whole lot to do with greed. They don't care about patients. All they care about is how much money they can siphon off of this system.
5 people to 5 million people, and as loud as we can possibly be so that our lawmakers have no choice but to hear us.
Turns on loops, it finds the end. Every silence builds an arc. They can't escape this. Their cracks will start to show. Their truth will break free. It's stronger than
the reality was, and when I started back in pharmacy, patient would come in, give you a paper prescription. You would just kind of guess about what their coverage was. But again, this was back at a time where we just had brand and generic drugs. We didn't have $1,000 drugs. We frankly didn't have hundreds of dollar drugs. So you didn't have to worry about the insurance coverage as much. Things were much more affordable. It was much simpler because we were just dealing with pills. And so you could basically manage off that piece of paper. It wasn't easy, it wasn't great. There was a lag in payments, lag in coverage. Formularies were just starting to come out 30, 40 years ago. We've got technology, and a PBM could sit in the middle and say, hey, pharmacy, here's the drugs that we want to cover, and here's how we're going to pay you, and you can do that in real time. And then it really started to expand because self-funded employers, Medicare, Medicaid, as they started looking into this insurance coverage for prescription drugs, they needed to be able to create a network. Do I want Walgreens in network? Do I want CVS in network? Do I want independent pharmacies in network? Then they could start creating all the rules. So then the PBMs took this very complex world and made it easy for employers just to contract with them and manage the whole benefit on their behalf. And again, 30 or 40 years ago, it was off an admin fee. They were really this pure thing trying to help, I think, community pharmacy get paid better and run a more efficient operations, and then employers figure out how to bring a better benefit to their members. But I would say really over the last 10 years is they've then grown, and we've seen consolidation from 20 PBMs to 10 PBMs to, let's face it now, really just 3 main PBMs that are all owned by huge healthcare conglomerates that are really 3 of the biggest 10 companies in America by revenue. and their whole goal is to work on behalf of their shareholder. Now we've lost that purity of what a PBM used to be, and they're just trying to make as much money as they can for their shareholder, and that's always at the detriment of the American economy, the American corporation, and definitely the American family.
Mr. Scott, let me start with you. You represent the largest association of PBM companies, I think. Is that right? Oh, the largest and only. Perfect. You're supposed to be making drugs cheaper for patients. Is that basically right?
We're supposed to help employers and plan sponsors administer benefits at a more affordable point for the consumers.
Okay, more affordable for consumers. That's patients. So you're supposed to be making would you say that you're succeeding?
We've had success in managing the net cost of drug.
I think the answer you're looking for is no. You're not succeeding at all. This data shows the percentage that Americans pay more than other countries for brand name drugs. In Canada, we pay 324% more than Canadians pay, 445% more than France, and so on. On average, all together, we pay 422% more than all of these other countries. Either you're the worst negotiators in the history of the world, or something's wrong with your business model. Which is it?
Those, if I may, Senator, those are comparisons of list prices. Drug companies alone, as we talked about earlier, set the list price. The PBM is negotiating down the net cost.
You're not telling me that consumers aren't paying more in the United States than they are overseas, are you?
I think the data would tell us that they are exposed to higher price points. And then it comes to an issue of benefit design. The plan decides what your copay
and the benefit. Here's the benefit design. The design of the plan benefits the insurance companies and you. It does not benefit the patients. Patients are getting screwed.
So yeah, they are the quintessential middlemen. They're the paper shufflers, but they've got everyone by the short hairs because they control the data, they control the formularies, they control the rebates, they control the costs. They have positioned themselves so that they control everything.
These are huge behemoths, and we've got 3 of them in our country that basically has control of 80% of every insured, including Medicare. You know, these PBMs, their profits are in the billions every quarter. So I would say, yeah, they're creating a lot of savings, and it's showing up in their bank account.
It's this big deal where Cigna has announced it's going to be buying Express Scripts. This had been rumored before. It's $67 billion, 67.1 to be precise. And it's a big consolidation actually within healthcare.
It is, and this is just sort of the latest in a series of deals that we've seen. You have, CVS buying Aetna.
Oh, it's like a license to print money to be a PBM. So Cigna bought Express Scripts for $69 billion. Cigna didn't pay $69 billion for a company that's not making loads of money. CVS Health is, I believe they're number 6. I was just recently looking them up. They're a $320+ billion company. United Health, I believe they're number 3. And then Cigna ESI, I believe they're in the top 50.
So the FTC's report, so this is the government report now, found that the top 3 PBM companies generated $7.3 billion in profits between 2017 and 2022. $7.3 billion. That's a lot of money. Why is it that nobody can afford their drugs in this country, but you're making $7.3 billion? That's more than the revenue of some nations.
The FTC has released a preliminary report on PBMs, and it shows that PBMs are increasing the cost of prescription drugs. They're having an anti-competitive effect on small businesses, and they're driving up costs for consumers. They're also limiting choice for consumers, the weaponization of formularies, that patients are not having the same medication choices that they otherwise might have. 70+ page report, over 300 citations by the FTC. This is a preliminary report. It's not their final report. And it was said by FTC that some of the reasons they are not able to issue a final report is because some of the PBMs have been uncooperative and refused to respond to the FTC's demands for documents. They've been trying to do this investigation for over 2 years, and the PBMs refuse, not all of them apparently, but at least some of them refuse to comply with the Federal Trade Commission. Now, I'm not an FTC expert, but I think it's pretty outrageous, for 2 years for large companies to just ignore the demands of the Federal Trade Commission. But I think it shows the arrogance of these companies that they say, we don't have to comply with the FTC. We're too powerful to have to be trifled or annoyed with you little FTC people. The FTC has said that they will take them to court if they have to.
Do you solemnly swear or affirm that
Tonight, the powerful middlemen managing prescription drug access for millions of Americans grilled on Capitol Hill. Executives from the 3 largest PBMs responsible for managing access to nearly 80% of all prescription drugs in the U.S. pushed back on allegations they drive up prices.
They're supposed to help keep drug costs lower, but the FTC says that between 2017 and 2022, the 3 largest PBMs, CVS Health's Caremark, Cigna's Express Scripts, and United Healthcare's Optum Rx made $7.3 billion by marking up drugs by hundreds or even thousands of a percent.
you're setting dramatically different prices for some medications across the country?
If you're not delivering an outcome to the people who use it, how long do you all think you're going to have a job?
I feel like the more I hear, the less I understand.
When you buy something, you usually know how much it's going to cost before you pay, but that's not always the case for prescription drugs.
Capitalism should work, but when we think about capitalism, it has to be followed with transparency and access to true data. And so at a very basic level, let's just talk about a gallon of milk, right? If Target wants to sell a gallon of milk for $2 and HEB, a grocer, wants to sell a gallon of milk for $40, capitalism is going to say, I'm going to walk into HEB as a patient or member and see $40 and go, I'm not going to pay that because I know I can go down the street to Target. So it works when we have this transparency. But in the PBM industry, nobody knows what their drugs cost. You show up at a pharmacy counter every single minute of every single day, an American does this, and they have absolutely no idea, first off, what it's going to cost. They have no comparison to know what it should cost. They frankly usually only know their copay or their portion, and we don't really know the greater cost of it that the plan or the corporation had to pick up. So capitalism totally falls apart, especially in the PBM industry, because nobody really knows these data points to make a better consumeristic decision.
And we're looking at a large plan in the Federal Employee Health Benefit Program. We found an MS drug that was marked up 47,000%. Taxpayer money marked up 47,000%. Not normal, right? But yet it happens every day, every single day. But now we're talking about healthcare. We're talking about access to life-saving medicines. And we're talking about taxpayer dollars. That's how broken the system is. A patient is walking with insurance and it's costing them money. And not only are they buying a more expensive drug, a portion of their copay is going to pay the PBM. The sad part is the pharmacy lost money on the insulin. So the pharmacy lost money, the patient overpaid by a couple $100, and who wins? The PBM is plus $250, they didn't do a thing. Patient doesn't even know. What's a better business if you're a profiteer or a robber baron?
Okay, so it went from $54.13 to $114.98.
Express Scripts shipped her medication, then charged more than double the listed price online. No notification.
Better Business Bureau is just advising consumers to use caution when considering doing business with Express Scripts.
The Better Business Bureau has had so many complaints about this popular pharmacy benefit provider, it's issued an alert about a pattern of complaints, from delays to poor customer service to billing issues.
And I don't understand why this isn't illegal.
But as an extension to the Mafia, drug cartels, I think the drug cartels are more transparent than PBMs are. Let's just be real clear. You know what you're getting out of the Cali cartel, full stop. Nobody needs to guess. You have no idea what you're getting out of CVS, Optum, or Express Scripts. Because there's no data, there's no proof point. They continue to hide and obscure things. Let's face it, their chief executive of each of these companies were just in front of Congress, and Congress is calling them out for perjuring themselves and lying to Congress. So if the first time is a public, we get to see these guys get questioned by Congress and they lie to them, what are they doing to everybody else? Because the PBM makes all the rules. Not only do they get to decide what they pay themselves, they get to decide where you have to get your drugs filled.
Why is it a good idea for the biggest PBMs to be owned by the biggest insurers, and now you're buying up pharmacies as well? Why should we allow that? How is that good for patients?
Profits are in the low single digits on
Your
average
profits
for
are
our
not
industry.
better than they've ever been?
I don't know on the trend over the years.
Yes, you
but
do.
it-
You know
the
exactly.
low-
It
the
is all
lows-
laid out in the FTC report. You absolutely know the answer. Your profits have increased and increased and increased, and now you are buying up pharmacies, and you're buying up pharmacies and you're putting independent pharmacies out of business, and you're doing it deliberately because you are giving special rebates and lower costs to the pharmacies that you own, and you are directing patients to the pharmacies that you own, such that if they don't go to a pharmacy that you own, they have to pay higher costs, they have to pay out-of-network costs, right? You're nodding your head, Dr. McGunn. You've lived this, right?
I have lived this. I live it every day.
Number of PBMs, meaning it's a competitive marketplace.
It's not a
Independent
competitive
pharmacy
marketplace.
data.
The biggest 3 PBMs own 80% of the business. 80%. And you're in turn owned by the biggest insurance companies. The problem is there is no competition. It's a racket. It's a total racket. And the people who lose are the patients who cannot afford the prescription drugs. It's time for this Congress to do something about it.
Do you solemnly swear or affirm that the testimony you are about to give is the truth, the whole truth, and nothing but the truth, so help you God?
Your company steer patients to affiliated pharmacies, yes or no?
The answer is no.
Dr. Costner?
No, sir.
Dr. Conway?
No.
You're under oath to tell the truth, and they lied.
PBMs have done like what's prohibited for physicians to do, literally on the grandest scale that it has ever been done, right? They are steering America's sickest patients, carte blanche, steering these patients into their pharmacy channels. And not only are they steering these patients into their pharmacy channels, but they're massively marking up the price of those drugs. And so, is there impact to patient care? Absolutely. Does it disrupt care? Absolutely. Does it delay care? Oftentimes.
Patient steering is rampant within PBMs, and patients may or may not even know it. By patient steering, by that we mean that patients are sometimes forced, more often they're given a choice, the choice being you can choose whatever pharmacy you want, but if you want your insurance benefit to kick in, then you must use this pharmacy. Or you'll have insurance benefit at multiple pharmacies, but if you want the lowest insurance benefit, then you must use the pharmacy that we tell you to use. So that the steering, the vertical integration of insurance companies and PBMs has really turbocharged the amount of patient steering that patients are subjected to these days.
You mentioned patient steering. I'm glad you're bringing that up because people hear about it, but it's like they don't know how to equate that, especially how it affects them and their community. So the best way I can say it, and this is intimate, we had a pharmacy we recently had to close down in Randolph, Wisconsin, that had a pharmacy there for 122 years. What happened that could possibly have a business that was the only pharmacy in town, fantastic reputation, all of a sudden not be able to be sustainable anymore? It's called patient steering, and here's how it occurs. So let's say the population of Randolph is approximately 1,800, but in about a 30-mile radius, there's maybe another 1,200, so 3,000 people. So 3,000 people, you can usually have enough to sustain a pharmacy. Well, 7 years ago, the local employer and or Medicare program says you have to go mail order. So maybe there's 300 of those 3,000 people that no longer had a choice. And let's say of the 300 people, 150 used to come to our pharmacy. They can't come anymore. They leave crying. They maybe even get mail order to still come to our pharmacy to ask for advice on it. So now we give service without having any comp, which we do because that's our community member. Then the next year, 10% more. Next year, 10% more. So unfortunately, the PBMs have been brilliant in killing their competition by death by 1,000 cuts. If it took 50% of our customers right away, that would be too blatant. But if every year for 10 years they take away 10% of your patient base where they can't come anymore, pretty soon you wake up one day and says, okay, there's not enough there to pay the light bill anymore.
So in that Federal Trade Commission study, they found that this leukemia drug was $97 on average at the local community pharmacy, the quote mom and pop shop. It was, over $1,000 at the local chain pharmacy, but it was on average $19,200 if you did it via mail order. So again, they set the price, they told you where to go, and somebody had to pay that $19,200 versus the $97,000. And this is someone who has cancer.
Today, the Federal Trade Commission released its second interim staff report focused on the abuses of the pharmacy benefit managers, the middlemen of drug pricing. This report focuses on specialty steering. The practice of specialty steering, PBMs, which are owned by Fortune 20 health insurance companies, designate certain drugs over which they have pricing power to call specialty drugs. That is a term of business, not a clinical designation. Then they steer these high-priced specialty drugs towards their own affiliated pharmacies. The effect is higher premiums and copays for patients and more profits for the PBMs. This report chronicles eye-watering abuse of specialty steering to the detriment of our independent pharmacists and for patients who need life-saving medications for diseases like multiple sclerosis, which in Massachusetts the PBMs were marking up by as much as 38,000%, or leukemia, which they were marking up by 13,000%, or HIV, which they were marking up by more than 4,000%.
So these are high-cost drugs, specialty drugs. And you know where there's dollars, there's going to be PBMs. So what the PBMs have done, and talking about patient steering and their own mail order pharmacies, is that the PBMs steer patients into their own mail order specialty pharmacies. So while we have seen mail order prescriptions remain pretty flat over the last 30 years. If you listen to the quarterly earnings calls for these big vertically integrated insurance companies, again, United Health, CVS Health is Aetna. Aetna runs CVS Health, even though CVS in theory owns Aetna, and then Cigna ESI. If you listen to their quarterly earnings calls, the growth areas for their companies are in the prescription drug, especially specialty pharmacy areas, but that's their growth engine for these companies. But the dollars, the amount of money running through mail order is now about a third of all the dollars are going through mail order specialty pharmacies. So small number of prescriptions, big number of dollars going through specialty mail order owned by PBMs. Because specialty drugs are often for conditions that, well, I wouldn't say they're rare, but they are. The stakes are much higher. There should be even greater pharmacist involvement. Sometimes these specialty drugs also require special storage. So, shipping them through the mail is really could be very hazardous to the patient's health because they need to be often cold stored and not exposed to high temperatures. And then how they're administered, it may be a certain time that they should be administered over another time, or how they're administered, slowly over 30 seconds. It would be hard to miss without a one-to-one interaction. It's exactly the opposite of what makes sense. But here's what makes sense for the PBMs, is that those big three PBMs that control 80% of all prescription drugs, their mail order pharmacies control almost 70% of all the specialty drugs. So if you're the average patient, if they're getting a specialty drug, they're probably getting it through the mail, and they're probably getting it from one of those three PBM-owned mail order pharmacies, not because they're choosing to, but because they have to. Yes, there's been studies that have been done by individual states looking at, is there a conflict of interest with PBMs using their own affiliated pharmacies? And as we mentioned earlier, CVS owns its brick and mortar pharmacies, but all the big three PBMs, and really the big six PBMs, all own their own mail order pharmacy. And yes, they did find that there are, in many instances, higher costs associated with the PBM-owned mail order pharmacies. In fact, they looked at two drugs. They looked at two drugs to treat cancer, and those two drugs, they found potential overcharging of $1.6 billion, with a B, by the big three PBMs. Just on those two drugs, $1.6 billion on two drugs that you, me, and every taxpayer watching this paid for.
Have you ever considered how the temperature inside your mailbox could affect your mail order prescription medications?
Most of those medications have specific warning labels about temperature.
And a medical concern that flies under the radar sometimes affects your prescription drugs.
What happens to them in the heat?
Many medications say to keep them at room temperature and in a cool, dry place like a kitchen cabinet. But the bathroom cabinet is not a good place since showers produce a lot of steam. One place you want to avoid at all costs is leaving anything in your car. On a 90-degree day, temperatures in a parked car can reach up to 120 degrees in under a half hour. This can negatively affect anything inside, from ibuprofen in your center console to birth control in your purse.
So mail order pharmacies fall under the PBM model as a way to control patients' access and use of drugs. But I'm sure you could find numerous cases, countless cases, of people who had their medications changed through mail order pharmacy. And of course, the mail order then controls how that formulary would work, and have numerous cases of people who would order their medications and they would arrive and they required special handling, but the patient worked or was out of town for the weekend, and their refrigerated medication would sit on their doorstep for a period of days. We also have countless stories of people that would receive a 90-day supply of an expensive medication, have an adverse reaction to it, or have it discontinued by their doctor and have to change. And the costs of these unused medications, and they couldn't donate them to any place because they were already dispensed in a container with that patient's name on it, would just go to waste. And those are individual cases. Imagine them in mass. I mean, it's right on the bottle itself that you get your medication that has the storage requirements on it, whether it's frozen, refrigerated, or at room temperature. A lot of drugs are like that. They degrade at a faster rate. I mean, their expiration date is calculated at that temperature. So if you have pills in a bottle that sit on your doorstep for a period of days on a sunny 100-degree day, I mean, I can't tell you for sure if that drug is still compliant with its expiration date.
NBC News investigates this morning an important story for the estimated 26 million Americans who have their prescriptions mailed to them.
Yeah, a lot of folks think getting prescriptions delivered can be convenient and certainly cost effective, but some people have told NBC News it can also be a source of frustration and in some cases fear.
Ohio issues serious sanctions against one of the country's largest pharmacy chains for endangering patient safety.
In most of America, they're not warned about this issue as they are forced to improperly store their medications. A lot of people don't talk about what's happening with access and how this is interfering with patient-safe access. Many patients are experiencing delays. Many patients are also, they don't even know that their medications are not being properly stored and that the issue is left unregulated. Mail order pharmacy, when it's the large 3 PBM mail order pharmacies, I do not feel good. I feel very concerned that they're price gouging. I feel very concerned that lives will be risked with delays. I feel very concerned that they may not properly package medications. My son, when he was born, was totally healthy. Just beautiful, blue-eyed baby boy, just curly hair. All of a sudden, one day I came home. I worked at a hospital as a social worker. I came home and I noticed that his eyes were glossy. He had like 100-degree fever. I took him to the doctor because I didn't think it could be anything major. It was within 24 hours and they're like, something doesn't look right. You need to bring him to the hospital. So I did. He ended up getting a transplant about a week later. It was just life overnight just changed. So it was a liver transplant from the flu. So he had the flu and it was just, it caused his body to have like an overreaction and his body started fighting off his organs. So it was just a hard experience to go through for our family, and I never want to relive that again. My son had lost his ability to talk. All of his first words were just gone. He had to relearn how to walk. At one point, they did say they didn't know if he would ever walk or talk again, but there were some beautiful physicians that really did give us hope and inspire us to hang on with him, that he would pull through and be okay. And I'm glad that we did because he's here with us today. But we decided to try mail order pharmacy about a month and a half after his transplant. And then I didn't know anything about this independent pharmacy, chain pharmacy, mail, it's just me, pharmacy's pharmacy. I didn't realize the importance of the different types of pharmacy and the treatment that you would get at each. They said, oh, you know what, that is a specialty medication. It's liquid oral transplant medication. We just don't feel comfortable filling that. You'll need to get that filled at a specialty pharmacy, maybe the hospital or a mail order. I'm like, okay. So I decided to try mail order. They shipped his medication on a 102-degree day. It was so hot that day. In Missouri, it was record-breaking heat. I remember filling the bottle and it's just like, gosh, it's hot, but I'm like, there's no way they would do this and it not be safe. Surely someone's making sure. But then it was probably about a week later, my son would get a call from the transplant nurse after he just got labs done. And she's like, Loretta, we need you up here. He's in rejection. It's terrifying already here. We just went through this horrible experience and he's fighting for his life again. At one point they said, Loretta, we're either going to have to give him this harsher chemo medication or he might lose his transplanted liver. And during that time, it was so hard. But then the next day, another doctor came and he said, we need to put in the port. We need to give him this harsher chemo medication as soon as possible. So I watched as nurses just held him down for 2 hours, just trying. I don't know if you've ever seen a toddler just having to get injections or having to get their blood drawn, but it is so hard at that age. So that whole time that they're trying, and my son is screaming and crying, and there's nothing that I could do to calm him. I thought about those medications, and I'm like, I can never again use mail order pharmacy unless I can ensure that it's safe. And I didn't. We ended up driving 1 hour to Cardinal Glennon to get my son's transplant medications. We had to go up there anyways for labs. You know, they have to get labs done a lot right after transplant. So it worked, and I trusted them. You know, I felt like they were the safest for my son. They worked with children all the time. And then in 2018, we're being forced to mail order pharmacy. And that's whenever I learned the worst about mail order pharmacy.
I am a new grad. I'm a newly licensed pharmacist from Southwestern Oklahoma State University. During my time at Southwestern, I was able to complete a mail order research project with some fellow students, as well as an advisor, over the exposure of mail order drugs to excessive temperatures, excessive considered by the United States Pharmacopoeia. And it's one of the regulating bodies as far as what drugs can be subject to during the shipping process, or even just in a pharmacy. That is then carried on by states when they regulate pharmacies. The standards are set in place for a reason. Every drug has a stability issue at some point. The temperatures we were looking at for USP guidelines in our research study, what is considered unsafe or excessive by our regulating bodies. The guidelines recommend that excessive temperatures of over 90 degrees Fahrenheit, your non-cold chain drugs like your tablets, capsules that aren't temperature sensitive don't have to be necessarily kept in the refrigerator. Those can be stored at like 68 to 77 degrees Fahrenheit, so anything considered room temperature. And that's what we go by in the pharmacy. And for refrigerated cold chain items, those are to be stored at 36 degrees to 46 degrees Fahrenheit. So that is all logged. It's in the regulation that we log those daily. But what is so perplexing about the mail order pharmacy realm is the responsibility of the medication once it leaves the pharmacy. So the mail order pharmacy would claim that it leaves the pharmacy when it's in the carrier's hand. But then they put that responsibility immediately on the patient. If they picked it up immediately, no problem. It wasn't sitting outside, it wasn't sitting in a hot mailbox. Well, that's not what our study looked at. We logged the temperature every 5 minutes from when we dropped it off at the carrier and it was priority shipped. So we shipped out to 10 different locations varying from about 50 miles to 1,300 miles. This was during the summer, so our limited resources, everyone was on vacation. And so we shipped them to those areas, which was actually a pretty similar representation of how far packages are shipped via mail order. While it was a small viability study, 80% of our packages, cold chain and non-cold chain, they reach temperatures considered excessive or unsafe by the FDA or the USP, the numbers I mentioned earlier. And with that being said, the non-cold chain drugs, the highest that we recorded was 121 degrees and some change, and it was considered over an excessive temperature, which would be 104 degrees Fahrenheit for over 10 hours. So that's just your normal tablets, capsules, in a manila lined envelope in the back of a truck. And then for our cold chain drugs, they are allowed brief transient spikes 77 degrees Fahrenheit, so long that it's not for over 24 hours during the shipping process. On all areas of mean kinetic temperature, average temperature, or the transient spike, all of our cold chain drugs fail. Our total number was 80% between non-cold chain and cold chain drugs. It's very alarming. I'm not going to say that it's considerably more alarming, because it doesn't matter to me or to any pharmacist how close to being okay a drug was shipped, or how close it was stored in our pharmacy to being a safe drug. We want 100% of our drugs to be safe. And for 80% of a small viability study to show up as considered unsafe by our current regulatory body, that is smoke. And our jaw was on the floor, because we basically opened a can of worms that is sitting underneath one of our biggest and most expanse methods for our patients to get drugs in our country. Convenience should not take priority when it comes to safety and medication for our patients. You have corporations that are funneling patients to use their service, and the patients, they don't know what's going on with their drug during the shipping process. And the most egregious example was a drug that was above the excursion temperature for 43 hours, almost 2 days at an excessive temperature with this transient spike maximum of 92 degrees. So that's like insulin. That's all of your injectable drugs. That's most of your injectable drugs that are being shipped. Just think of how hot 92 degrees is when you get in your car, and think about that non-cold chain drug that was shipped and hit a transient spike of over 121 degrees. Those spikes were when the drug was in the back of a truck. And if it's in the back of a truck for days at a time during transit or during the shipping process, it's not going back in a warehouse. And I believe patients should have the right to choose where they fill their prescriptions. And if safety comes into play, they should definitely have the right to choose where they fill their prescriptions. You said we take an oath as a doctor, as a pharmacist. I took an oath just like all the other pharmacists. And at our pharmacy, we have to adhere to certain regulations, that one of them being how we store our drugs. More specifically, the temperatures at which we store our drugs. So you're saying one of the biggest, if not the biggest, ways that most of our Americans are getting pharmaceuticals or drugs, it's hitting these temperatures before the patient ever gets control of their own medication. And I believe at that point, it's not the responsibility of the patient, it's the responsibility of the pharmacy. If I deliver a drug to someone down the street, that drug has to get there in a safe manner. It cannot be altered physically, it cannot be altered at a temperature level, moisture level. When the patient receives the drug in their hand, it should be in a professional manner, pharmaceutically elegant, and it needs to be safe for the patient to consume, as well as effective to help the patient for the whole reason we're here in this medical system. There should be a human element to healthcare. We are serving patients for a reason, to help them overcome certain conditions, to maintain certain conditions, and to increase their activities of daily living. And to totally remove that interaction, a drug that is exposed to any unsafe environment, it can become less efficacious and it can become harmful to a patient, certain drugs, or if exposed to certain elements. It was so frustrating for a patient that had serious health complications and could have resulted in death.
So I found out that mail order pharmacy, like I thought someone was making sure that temperatures were safe. No one's truly ensuring that it's safe. So that was the first thing I'd find out. But even prior to that, it was just, we would get the letters of, you're being forced to CVS mail order, basically. Use our pharmacy or pay 100%. As most people, I think, feel when they get those letters, it's like, how un-American is that? Like, this is America where we should have freedoms to choose what businesses we want to support, what businesses service our child's needs the best. And to totally say you can only use this one pharmacy, it felt very monopolistic, and it didn't feel fair to the patient. It certainly didn't feel fair, for the hospital pharmacist either. I asked the pharmacist, I said, why aren't they going to allow us to fill his medication here? And he said, all it says is that this is an inappropriate place to fill this medication. And I said, I feel like this is the best place for me to fill my son's medications. You work closely with his doctors. You work with kids like him all the time. And I don't have to worry about delays and improper temperature storage. So then I would give CVS a chance. They promised me an ice pack. It was a hot day in May, and my son's medication would arrive without an ice pack. So then I started questioning them. And I would just ask, how come? Well, we can't really control the trucks. We can't really control UPS. Well, then why did you promise me an ice pack? Can't you at least put that in his medication? Do I have to only get it if I allow it in these trucks, which at this time I had connected with a UPS petitioner who told me those trucks reach 120 to 170 degrees. And she sends me pictures of how hot these trucks are from UPS drivers taking pictures. And I'm like, people's medications are in there. Several days from these mail order pharmacies, they're in there. And it was so unethical. And no mom, no patient should have to risk any integrity of their medication for the profits of these corporations. So I had to know, how much are they profiting? How much money do these employers think that they're saving, forcing us? And I would learn how to find out how much they reimburse themselves versus how much they would reimburse our local pharmacy that we use. They reimburse themselves over 10 times more as they force their specialty pharmacy. It's just how.
Can you say it again, please?
They reimburse themselves over 10 times more than what they reimbursed our local pharmacy. So right away, I'm learning this has nothing to do with cost. This has a whole lot to do with greed. They don't care about my son. They don't care about patients. All they care about is how much money they can siphon off of this system. Yes, we had a lower copay, which sadly, that's what too many only look at is the copay. But they gotta start looking beyond the copay like I did, because when you look at how much they reimburse themselves, what does that do to our premiums? I don't trust them at all to ensure that not only are my son's medications safe, delivered timely, but that they're also not price gouging.
Most folks won't believe the following, and it has been illegal, even though most folks don't even know it. It's called a gag clause. The patient comes in, and the latest scam is some of these cards. Hey, I got a card. If I get this, I get a better deal. And we're going, yes, but you have no idea that if you just ask us our cash price, we're always going to be better in this deal. Well, then why aren't we transparent with our cash price? Because we can't, because we can actually get kicked out of network if we are actually telling people that they can get a better cash price than their copay. So literally times where a patient can come in and their copay might be $50, and we'd say if you don't run through insurance, your cash price would be $20. I mean, it's hard to fathom that that could be true, right? Like, who would ever think that would be normal? Because that's you think that the insurance company is on your side. So they don't realize that the $50 copay, they're actually pocketing $50, paying us $15 for a drug that probably cost us $13. Right? So we're happily sell it for $20, save the patient $30. We actually get a margin that lets us pay the light bill versus that $1 that gets us out of business faster. When you're able to have people have no clue that they're being forced into a higher priced drug, that you are able to exert your middleman influence. Let's go back to insulin. How is that not a form of corruption? You're taking something that costs $6, artificially inflating it to $5.94, so you're able to get a big rebate to line your own pockets, and along the way you're actually lining the pockets of 3 other parties, all that's absolutely harming and literally can show a direct correlation to killing people. I mean, to me, this has been, I really like one of the quotes we have is, Mafia is small ball compared to what PBMs have done. So to me, it's like, this is the definition of racketeering.
When I first heard the term pharmacy benefit manager, it was like, oh gosh, just another acronym, PBM. There's so many acronyms in medicine. But, I started learning about them, almost 15 years ago, but didn't get really, really interested until about 12 years ago when a new drug was coming onto the market to treat rheumatoid arthritis. And the manufacturers went around to all the rheumatologists trying to get them to, please, will you prescribe this new drug? And we kept saying, price it right, because at that time, the most widely used drug, it was somewhere between $1,000 and $2,000 a month. So this was a long time ago. Well, they ended up pricing it the same. And when I asked the drug rep who came into my office, why did you do that? And he said, we had to. And this was 12, 13 years ago. So what do you mean you had to? Well, that's what we were told. Well, as it turns out, they did have to. Because if they didn't price their drug high enough, the pharmacy benefit manager that decides the what, when, where, and how much of drugs would not let them on the formulary, mean they would not be covered by the insurance company. And the rest is just a bizarre, mafia-like story. Basically, you think of an auction for a piece of art, the highest bid gets it. The manufacturers want to get covered on the formulary because, let's face it, if you've got an expensive drug, nobody's going to ever take it if it's not on the formulary, if it's not covered by your insurance. So the competition is fierce. And unfortunately, it's not the lowest priced drug. It is a percentage of the price that gets kicked back to the PBM that needs to get bigger. So if you've got a $1,000 a month drug and you're going to kick back 50%, if you're the manufacturer, you'll promise the PBM $500 every time they fill a script. And then another manufacturer comes up and they have a $2,000 a month drug and they're going to kick back 50%. That way the PBM gets $1,000 versus just $500. Which drug do you think they're going to pick? They're going to pick the one that kicks back them the most money. And we think, oh, well, of course, that'll trickle down to the patient and they'll pay less. That doesn't happen. It is a form of racketeering because it's anti-competitive to begin with. Yes, it's competition, but it's the kind of competition that raises prices. I mean, we talk about having a drug pricing crisis in the United States, and yet we have allowed the method for drugs to be chosen to be covered by insurance companies to favor the highest priced drug. I mean, why would we do that and then say we have a drug pricing crisis? We have a formulary construction crisis. And it's just very difficult because what happens is the PBMs talk about, we pick the drug that creates the most savings. And there's this term called lowest net cost, meaning, yeah, if you make more money on this, it's lower net cost for you. But the patient doesn't get the benefit of those savings. All they get is their physician being told, you can prescribe that drug, but we ain't going to pay for it if it's the lower priced drug. And that has happened over and over and over again. Until we change how formularies are constructed and the incentive to put higher priced drugs, we're never going to solve the so-called drug pricing crisis. The outcome of their decisions is if they're practicing medicine without a license, because they basically tell me what drugs I can prescribe, and they'll go, oh, no, doctor, you can prescribe whatever you want. We just won't pay for it. But when we're talking about prices that are over $100, it's been shown that there's an adherence rate. Patients sometimes, when they find out how much it's going to cost, if it's over $100, oftentimes 50% of the patients don't even show up at the drugstore because they know they can't afford it. So when you're talking about these prices, these list prices, without the kickbacks, in the thousands of dollars, the patient loses access to those drugs.
Our son Cole was 22. He was essentially, when I was pregnant with Cole, we knew he would have asthma because Bill and I both have asthma. We were prepared. He was officially diagnosed around 18 months. When he was maybe preteen, he was prescribed a daily steroid medication. We both were prescribed it as well. And I always say that like that was life-changing for all three of us. Cole was able to play sports. He was able to live a normal life. He had that discus every day and he was good. He moved out on his own probably about age 20. He had moved in with his childhood best friend up in the Appleton and Green Bay area. He was doing well. Cole struggled for many years with school issues, ADHD, severe depression. So it was really great to see him kind of go out on his own and finally find his people in the world. He had texted us on a Monday and was having trouble breathing. He had texted Bill. He was trying to use his nebulizer, which again is something we had for years at the house for times when he needed it.
About 45 minutes later, he had actually called me. And his biggest concern was, what insurance do I use?
To go to the ER.
Yeah, to go to the emergency room. Because I could hear his labored breathing. I mean, me having asthma, I could tell exactly where he was at in his asthmatic attack. And I just get chills still thinking about it. And I said, get to the hospital. I knew there was one close. I said, call an ambulance, do whatever you need to do to just get there. Just go to the hospital. Don't worry about insurance. He had told me that his roommate was actually at the house that evening. He drove him to the emergency room. As soon as Cole hit the cold air outside, though, it was 22 degrees below zero roughly that night. It was one of those deep freezes in Wisconsin, and that really triggered his asthma. On his way there, his breathing got worse, and he actually went unconscious in the car. Yeah, Mitchell had grabbed his hand and was trying to feel a pulse the whole way there. And the last minute or so, he said that there was no pulse. And when Cole did arrive at the emergency room, he was lifeless. They had to resuscitate him to bring him back.
We later found out that he had suffered a cardiac arrest in the car, is what we assume had happened, which is why Mitchell could no longer feel a pulse. And then the next day, that Dr. Long would come back and say, you know, he had us standing by Cole's bedside, I remember, and two of the most amazing nurses were behind us. And I just remember Dr. Long, you know, saying things like what we thought we saw, the hope we thought we had. I remember we grabbed hands, and I remember the nurse pushed a chair up behind me because she knew, like, we're going down. And we did.
It's a blur, but I remember just collapsing in the bed.
Yeah. Yeah, you collapsed on his chest, and we couldn't believe it. Like the day prior, we had just a glimmer of hope. And on Sunday, January 21st, he passed at 10:06 p.m. He worked so hard to get to where he finally was, you know. He went through years of severe depression, not wanting to live. And then he finally got to a point where he was happy and loving life and going out and finding his people in this world that, you know, he fit with. And to have something like this take him from that after fighting so hard to push through adversity in life, it's unreal. It's unreal. Even at the ICU, his roommate was there, his best friend, Mitchell. And so he was like our only kind of source of like, what the hell happened? And it was Mitchell who told us he was out of his medicine. And we're like, what? Like, how? Why? How? Mitchell said, yeah, we went to the pharmacy. And he said, I don't know, Cole went up to the counter and came back and showed me on his phone that it said like $539.18. And Cole was like, I can't afford that.
That same medicine for a 90-day supply last year was like $70.
When Mitchell told us that, we were like, what? You know, again, like your mind just starts spinning like, no. Like he must not have given him his insurance card. Like there had to have been a mistake. Like this cannot be. So we had like, that's the only little piece of information that we had that could have led to this. We didn't know how, why, what brought us to that $500 price tag, and within a matter of 5-6 days was in the ICU. Never even heard the 3 letters, the term, the nothing.
Not having an understanding of, we go to this doctor, he gives me this piece of paper that says, take this, and when I drop it off at the pharmacy, I get there, and I sometimes don't even get what they want me to have. Like that was the
Yeah,
biggest thing. We were kind of
but
like,
I never knew what had happened between those steps.
Yeah.
Things start to make a lot more sense. Formulary.
the formularies. That's
changes.
and that's the biggest thing with Cole right there. His formulary changed on his discus, and it was moved from a tier 1 to a tier 3, which put it up at the higher price point. You know,
Complete lack of transparency.
yeah, they didn't tell us they were doing it until we walked in the pharmacy.
They were saying that the doctor needed to prescribe something cheaper. Can you make a commitment today that you'll privilege the doctor's recommendation over the bureaucracy's recommendation?
I wrote a prescription on October 14th. I saw the patient 2 weeks later. He still did not have the medication. And then the patient's PBM CVS Caremark took the prescription. So this happens very frequently.
Right, which presents consequences to your patients.
Definitely.
You know, the doctor prescribed the generic, the patient went to the drugstore, and the drugstore said, I am sorry, that's excluded from your formulary. The only one that's covered is the $10,000 a month drug. And he started naming off all these drugs where the higher priced drug is preferred and the dirt cheap generic is excluded. Now, you would think if they're basing this formulary on science, you know, looking at all of the studies as to which ones were the best and which ones were the safest and using price as something, they would all have very similar formularies because you look at the science and it says one thing. Oh, no. All the 3 big PBMs, they all have different formularies, and they change it from year to year to year with no science behind it. So patients are getting harmed. Doctors are getting, it's another form of moral injury because we go, you know, to medical school to come out and take care of patients. But if you take away our ability to take care of a patient and give them the drug that we know is the best one for it, and we're forced to use another drug, and we have to watch our patients suffer. I mean, I stay up at night worrying of the ramifications of what's going to happen because I know the patient isn't on the right medicine, but they can't afford the right medicine because it's no longer covered because the manufacturer didn't kick back enough money to the PBM to make it to the formulary. And you know, and that's the honest truth. And that's how patients are treated in the United States. So now the PBM comes in and tells the manufacturer, unless you pay me money, you're not going to get on to the formulary. And it could be a really good medication, and it could actually be a medication that's in lower priced. But because the Mafia is in it to make money, it's all about the money and, you know, who cares who gets hurt? The same way the Mafia comes into a town and demands money from businesses. And if they don't pay up, well, you know, they could get whacked. If a manufacturer doesn't pay up, they get whacked, but in a different way. Because as I said, if you've got an expensive drug, I don't care how good it is. If you're not on the formulary, nobody's going to take it. It's whoever has the power. And who has the power in this situation is actually the PBM, because they've got the holy grail. They've got what the manufacturers want, which is not only placement on the formulary, but preferred placement.
The concept of a formulary has really evolved even in the last 10 years. Because, again, 10 years ago, we didn't have specialty drugs. So we didn't have a bunch of the injectable, high cost, tough to administer, tough to ship because of special storage and handling requirements. It was, again, we were in a world where we had pills. And the formulary was created just to say, here's the drugs that we're going to cover. So if you're a patient, the PBM dictated what your doctor could prescribe. Because if a drug wasn't on formulary, they didn't like the doctor prescribe it. And back then, there wasn't a lot of exclusions. At the same time, as manufacturers grew, very competitive products, and so the PBMs are sitting there saying, well, do I need both of these drugs on this formulary? Because I, the PBM, get to decide what drug I cover. And they would go to these manufacturers and start extracting rebates out of them. The PBM would say, what's it worth to you to get access to my lives as a PBM manufacturer? So then the manufacturers have to pay these rebates to get their drug on formulary, knowing whichever one pays the most gets on formulary, the other one doesn't get access and sell any product. So it used to be that the formulary, I think, was a true clinical reason to make sure that manufacturers were bringing high quality drugs to market that benefited the PBM's membership. But the PBMs have evolved this, frankly, into an aggressive profiteering engine to make sure that manufacturers are competing against each other for profit purposes, and then they're just extracting as much money as they can, keeping a substantial portion of these dollars that manufacturers give, but then tell the American public and corporation, hey, I gave you all these rebate dollars, you're welcome, I used my size and scale to buy down the cost of your drugs, but frankly, in my opinion, always in a way that's not helpful. And I think it's really come out of this fact that you see your primary care doc as a patient, they give you a drug. You see your cardiologist as a patient, they give you a different drug. You maybe see your nephrologist and they give you a different, so now you've got just different providers giving different drugs, and everybody thinks for all these unique ailments that chronically people have, I should just keep giving them drugs. And when drugs get approved, it's the singular drug that's tested for the singular thing, and there's not a great body of evidence and say, okay, but what happens when you take 3 drugs at the same time? Knowing that those are all in the body at the same time and they're doing these different things, we don't have, I think, good studies out there to really prove that we might not want to do that all the time, that more is not always better, and it's probably causing problems that then doctors put more drugs on, and then you get more problems, and they just pile more drugs. This concept of more drugs to cause more problems is probably a real issue.
So controlling the disease process, particularly in my drugs, but it's with any disease process, whether it's cardiovascular disease, whether it's diabetes, you need to control the disease process. And if you've got a patient stable on a particular drug, the last thing you want is having that drug pulled out from under them. And then the types of medicines maybe that you have to use in order to get them back stable again either cause other side effects or you can't even get them. And that's been the problem with this formulary construction, is they take patients who are stable and under the guise of savings, change the formulary. The patient loses control of their disease process, ends up sick, ends up with an infection, ends up with a heart attack, ends up with joint replacement, you name it. And it ends up costing all of us, the system, more money, while the PBM is still raking in the cash from the new drug that they put on the formulary and the old one they excluded from the formulary.
Cole had ADHD, and we changed insurances because we experienced the whole step therapy process with his ADHD medication. But I never knew
that was step therapy.
I didn't know it was step therapy. I didn't know anything. I just knew that what was working for him was now no longer covered or whatever. I didn't know why. I didn't know who was in charge of that. I mean, yeah, I had no idea.
I just remember always thinking, oh, that's because they just want me to use a generic instead. This is the basic.
Yeah, it's cheaper for me.
Yeah,
or something like that.
And that seemed reasonable, but when the PBM came into our world and we understood a little bit about it, it was
blown away.
Yeah, blown away. It's unrational. I mean, like, what is this?
Yeah.
Then you look at all of the other tools that PBMs use to control the formulary, whether it's step therapy, where they decide which drugs you can take in which order. And a form of that is called non-medical switching. It's where a patient gets switched or whipsawed to another drug because of a non-medical reason. And we know what the reason is. It's financial for the middleman, the PBM, who's constructing the formulary. There's exclusions. It's just another way that they can funnel people to the drug they want them on. Not only does that one particular episode create a delay and an increased cost for my patients, every time another manufacturer gives them a better price, I'm using it in quotes because it's a kickback, they can switch my patient around. My patients get whipsawed back and forth from drug to drug, and they can legally do it up to 6 times a year. So my patient will be stable. They may have been stable for 3 or 4 years treating their rheumatoid arthritis. Come January, a new drug comes on that kicked back more money to the PBM. My patient can't take that drug anymore. Oh, sure, they can take it, but they can't afford it without it being covered. And then, without letting anyone know, 3 months later, they've changed the formulary again because maybe that other drug now has come back or a different drug has offered the PBM more money, so they change the formulary. They don't let the patient know. They don't let the doctor know. The patient shows up. The drug that they've been taking now is excluded. They are being whipsawed. It's not like someone gently takes them and walks them over to another drug and explains, this is going to work just as well, da-da-da-da-da, because it doesn't. It's like they've been taken and they've been like cut off at the knees. And then they're cut off at the waist, and then they're cut off at the neck. They're being whipsawed back and forth to whatever drug makes the most money for the PBM. And the PBM goes, oh, no. We're creating savings. We're choosing the lowest net cost drug. And oftentimes, they put in a drug that the patient had already tried before and failed. And unless that state or the government has a law saying if a patient has already failed a drug, you can't make them take it again, that's the only thing that's stopping them from making the patient take it again. I'm never going to prescribe a drug that the patient already took that either didn't work or caused them a side effect. But the PBMs, they have no qualms about saying, oh, I'm sorry, you're just going to have to try it again before you get to that drug that was actually working. Legally, they can do that, unless you pass a law saying they can't. Should be the other way around. But our system is upside down in so many ways when it comes to the legislation controlling, basically, the insurance companies that are practicing, in my opinion, practicing medicine without a license. And was walking around with a pediatric rheumatologist, and she told me about step therapy. It was a 4-year-old child, I get choked up, that had been diagnosed with rheumatoid arthritis. And it causes swelling, it causes pain, it causes children to not be able to walk, to be able to hold things. That mother had to go through 4 different medicines before they got to the drug that the pediatric rheumatologist had originally prescribed. Was that drug expensive? Yes. But that poor child had to be carried into the bathtub and out of the bathtub month after month after month until the mother and the pediatric rheumatologist could get the child onto the right medication. Appeals had been filed. That's what step therapy does. Imagine if that was your child. I think telling their story, telling how they have been harmed, whether it's through ridiculous prior authorizations, it's where the doctor has to ask the PBM permission to use a medication, as if the PBM knows best whether they can use that drug or not. And just the delay, there's been a couple of studies, but it has showed, particularly in rheumatoid arthritis patients, even the prior authorizations that have been approved eventually, the patients have had to go on thousands of milligrams of steroids before they got to the drug that was eventually approved. So even something as simple as a prior auth can hurt the patients. Here you are, you're sick, you're poor, you have a chronic disease, and so you can only afford a high deductible plan. But because of all these things, you don't deserve to have your deductible covered by that copay card. They use the word, they don't have enough skin in the game. Try being poor and having lupus. There you go. The stories are just unbelievable.
Have you? We need to breathe. The MS patient needs to survive to function. The diabetic patient needs insulin to survive. The list goes on and on.
They're greedy. They want money.
And at any cost.
Yeah, any cost. That's the...
Where inhalers and things like that were maxed out at $35. So I'm, again, baffled. If they're all maxed out at $35, where was the other $500 going to go? You know, it's like extortion. How is that okay? It's not okay, right?
I've learned the kickbacks, the rebates, the step process, all those little tactics, as I like to call them. You know, they claim them to be ways to save the patient money or make insurance more affordable, give people the best options. That's just not the case, and there's a lot of wool pulled over people's eyes or something, and it's because it's a money game, and when you got billions of dollars being made.
Every time we've tried to get a PBM to be more transparent, or we find out another way of their profits, what happens is they create a big black box right around that. So it went from rebates to fees, and now they've actually started companies offshore in order to hide the rebates even more. Well, now some of the PBMs have actually started working with manufacturers and are co-producing and co-branding drugs. So now you have the PBM sort of owning a subsidiary that is sort of producing drugs. You can't decide the formulary and then make a drug and make that drug the fail first drug on your formulary, which is happening now with some of the biosimilars. And the scary thing is, and United Healthcare danced around this in front of Congress, but they employ over 90,000 doctors. But that's a scary thought. Now the insurance companies owning the PBM, owning the pharmacy, owning the specialty pharmacy, owning the bank, owning the data. Now they own the doctors too.
What happens then, right? Is that pharmacy an advocate for the patient? Is that physician an advocate? There's going to be patients who they're not even going to know that there may be some other drug out there, because they're going to have the doctors prescribing to the formulary and they're steering it to the pharmacies, and so it goes. And so the drug with the highest rebate is going to be the drug that the doctor prescribes. It's going to be the drug that the pharmacist that's owned by the PBM dispenses. And you know what? The patient isn't going to get the benefit of that rebate. And they may not even know that there is a cheaper generic available. And that's the world that we live. The Mafia is small ball compared to what PBMs do. The scale that PBMs do it, the brazenness that they do it, and the sophistication. If criminals understood what PBMs were, PBMs is what they would aspire to be.
It's a very good secret that nobody knows that drives a whole lot of money back to the shareholders of those organizations.
With their entire behemoth vertical integration, I mean, are they too big to fail? Are they too big to legislate against? I don't know.
It is like a mafia. The way that they work with each other, the way that they have so much control over regulators, over legislators, over the people that work underneath them, the other companies that they're competing against. And although it may not look like a battlefield, it's not guns and knives drawn, the harm is just as great. And they're getting by with it, with killing people, causing people to suffer without any consequence.
We've been almost conditioned as a country, well, that's just the way it is. But we've never asked the question, well, how much does it cost to make? That should not be an area we get extorted. It's not an area we should be manipulated or blindsided or black boxed. There are people literally dying because they can't afford their medicines. There are people literally going bankrupt because they can't afford their medicines. How angry are people when they realize the cost to make a drug is $16, but they're getting charged $7,000? But when it comes to medicines, like, this isn't about luxury. This is about potentially life and death. A young man died because something that probably cost $5 to $10 to manufacture, that maybe should cost $60 to $75, goes to $5.38 where people can't afford it, so they die. That's manipulation. That's gross. That's the opposite of what healthcare is supposed to be, but it is today because of the manipulation of these middlemen.
Unfortunately, Cole's story is the most basic example of how this is just so screwed up it's not even funny, because he tried to get an inhaler that should be a generic inhaler that costs $50 or $60 a month. So overall cost for this inhaler should have been $600-700 a year. Instead, because he couldn't afford his inhaler, he ends up having how many days in the ICU? He ends up passing away because of it. So even just throw the spend out. I mean, the outcome was terrible, but even if we back up from that, that was hundreds of thousands of dollars in medical bills just because we wanted to inhibit his ability to afford a really low-cost generic inhaler. And again, that happens thousands of times every day. We absolutely think that PBMs aren't just looked at in a void, but it is an economic impact, because when you spend more money on drugs and companies have to spend more money on their prescription benefits, that's less we can put into wage growth. That's less we can invest in new equipment. And that frankly hurts the US's ability to continue to compete on the world stage. This concept that really started in 2018, where we saw many of these large companies incorporate, so it's the PBM is together with a health plan, together with a mail order pharmacy, a specialty pharmacy, and all of these entities are under common ownership. It was sold to the American public that if we allow this vertical and horizontal integration to occur, it's going to drive down cost and improve quality. Well, we're 6 years down the road and costs are spiraling upward. We are unhealthier more now than we were 6 years ago. So it is very obvious that when you put entities under common ownership, it allows them to create more opacity. It allows them to drive more profit to themselves because, yes, they get to decide what they pay their own pharmacies, and then bad things really start to occur. I think the first thing is we need to break these guys up. We should not allow a PBM to be under common ownership with a specialty pharmacy, a mail pharmacy, and a health plan. And if we are going to allow that, then we need to make sure that we have full visibility and access to data and pricing. So it's either let's get full transparency or let's just take the nuclear option and not allow them to decide what they pay themselves. because again, they're working in Wall Street's best interest and their shareholders. They're not working in the American corporation or family's best interest.
I mean, they're publicly traded companies, you know, and my son, who's an attorney, he goes, Mom, their fiduciary responsibilities to their shareholders and not to your patients, which is, well, maybe we should make health insurance companies public utilities. And, you know, they get a bit of a profit to keep the whole thing going, but not this obscene amount of money that's made on the backs of the patients.
And ultimately, they need to go back to being prescription processors. Because we do need someone to process a claim. Doesn't have to be a PBM. With technology today, there's probably lots of options out there. But if they happen to have the most efficiency and can do it at the lowest price, and it's a competitive price, fine. But we need a prescription processor out there. We don't need someone to hold everyone in the pharmaceutical channel, including patients and pharmacies, hostage over their prescription drugs.
What they're doing, they should not be able to get by with. Every day of delay should be a penalty. Risking lives is not okay. And to feel as parents that we have no other option should never happen in America. We should not be seeing these patients suffer and die. And giving a gift of life is just so precious. They deserve for their loved ones' gifts to be honored and to be cherished and be kept sacred. Their lives are being risked with delays. Children going without medication for days who had transplants, it's really hard thinking about when my son, he got his transplant that night. There were 3 livers that the doctors had to choose from. And I always think about like how giving those parents were, because that would be a hard thing to do in the worst moments of your life. And then here you have this corporation who is going to cause you to risk that precious gift of life that those families gave. No, that's not okay. We're not going to let you do that. You know, and that's why I told my husband, I'm like, I'm going to become an advocate. I don't feel like anyone's doing this, and we need someone on our side. So I do it a lot for that reason, for the people that have given the gift of life, for patients like my son who deserve a better future of pharmaceutical care. I was afraid to even go outside of my doors for like the first week because I thought for sure someone was going to possibly come trying to find me because they've gotten by with this for so long. It's just scary to even make a lot of noise. But the more that do it, the safer I feel. And the more attention that's brought up about these issues, the safer I feel.
And somehow, I don't know what we can do except bring those patients' stories, because I think when a legislature can hear that story, and if it's just one of them on there that has they themselves or a relative has gone through something like that, you need a champion. And you need a champion that won't succumb to politics. So a little bit of education and then bring the patients out. And we can show them how they make more money by harming patients. So every card, letter, it's better to have the patient come and tell their own story or write it in their own words or make a phone call.
And as these patients were testifying, telling their stories, and the pharmacists were telling their stories, the lawmakers were riveted. One trip to the state capitol and they told their story. And you know what? It was done, right? After that hearing, I think the Speaker of the House issued a press release that said, you know, PBMs are on the menu, right? Like, we are going to do everything we can to rein in these practices. It's helping the patient, right? Because the more the patient knows about the system and what's happening to them, you know, when they're overpaying, but the more that patients understand, you know, what is happening to them and who is profiting, the more patient advocates we're going to create.
Makes me very angry. One of my therapeutic options, as I'm calling it in my reform and everything, is, I'm doing social media. I'm getting out there contacting representatives, assembly members, congressmen, anybody that'll listen.
I think it's a matter of as many people and as loud as we can be is the goal. So 5 people to 5 million people, 5 postcards to 5,000 postcards, just being as persistent and as loud as we can possibly be so that our lawmakers have no choice but to hear us. No human should not be able to access a medicine that is prescribed to them by a physician.
Our story is a tragedy. We live that every day. We know that someday we'll bring justice for our son. Not only for him, it's going to be for everybody. And this affects everybody. We want to fix this so no one else dies. That's what we want to do. Yes, we've suffered our tragedy, and I don't want this on anybody. And if people don't get involved, they don't get loud, this is going to continue. The PBM reform mission is real, and it affects everybody.
If we could just come together, all differences aside, I don't care, what beliefs, political, healthcare beliefs, just the number one thing is that we take care of each other. I just wish that people would come together more in that way and realize what a powerful impact they can have if they would just step forward and use their voices for each other.
If every 100 people watches, even 1 or 2 says, okay, I've had enough, I'm going to call my local legislator and says, okay, we need to have PBM reform. We need to fix this because it affects all of us. That will make this extra special. Because if there is an army of folks that are going to both the local and federal legislators says, we've had enough, we need to fix this, we're becoming more educated, you can't lie to us anymore, we see through your lies. It's amazing how many incredible people across the country are fighting the same fight. It's not just us. As we reach around the country, there is an army of independents and patients and patient advocacy groups and physicians, folks who actually give care to patients, who are all saying we've had enough. So hopefully we are just one of the arms locked in with others that says this is just one more piece of information that we've had enough, and we're hoping to connect with enough people to say this is what's happening, we can fix it. And we've been asked by legislators that the last thing we need is for enough people at home to know what's happening and call up and says enough. We have incredible facilities, incredible people, incredible technology. We can prevent 80% of disease. Then why aren't we? Because the current health plans are designed to healthcare profiteer, not to actually help people prevent disease and lower cost. Who wants lower cost? Everybody else. What patient doesn't want to feel good and feel better? What employer doesn't want to give more benefits to have their people healthier and happier? And you're going to see all kinds of evidence. And the good news is we already know how. We just got to do it now.
They thought we'd stay